Afternoon, everyone. My name is Ruben Manohara. Thank you very much for inviting me to talk to you guys and for joining in this afternoon. For those who don't know me, I'm a shoulder and elbow surgeon. I just joined Roland and Bernard at the Shoulder and Elbow Orthopedic Group about 2 months ago. Prior to this, I was in the public sector for about 16 years, and I just left the National University Hospital. My main practice is just shoulder and elbow work, but I do the whole range from fracture surgery to joint replacements in the elderly, as well as sports injury. And I figured it was this last group that would interest you guys. So hence today's topic, tackling shoulder instability. Okay, so we'll just get on with it right now. So recurrent shoulder instability can be a very challenging problem to manage. And what I hope to cover in this talk is a bit on the pathoanatomy, things to look for in history, examination, and investigations in your evaluation of the patient. And then I'll share with you the procedures that we as surgeons have in our armamentarium to treat the problems, the Bankart repair, the remplissage, and the ladder J, and also share the outcomes and the problems with each and the evidence behind it all as well. And then at the end of it, we'll have a summary, and then we'll have time for the question and answers. Okay, so as you all know, the shoulder joint is the most mobile joint in the body. You know, you can move it forward, you could extend it backwards, you could adduct, or you could swing it out, abduction, and you can internal and externally rotate your shoulder. Or you can do a combination of any of those 6 motions and position your hand anywhere in space. And that's called circumduction. It's truly marvelous. And that's what I like about the joint, but with this great mobility comes that inherent risk of instability as well. A quick revision on the anatomy, I'm sure you guys know this all. You know, your main bones forming the shoulder girdle are your clavicle, scapula, and humerus. And the common joints that we treat are the AC joint superficially, and then you've got the glenohumeral joint proper, which is the ball and socket deeper underneath. The next level of structures around the shoulder joint would be your muscles and their tendinous attachment to the bones. So you've got the 4 main rotator cuff muscles, and then what's often ignored by some is the periscapular muscles. There's 17 muscles that attach to the scapula, and you know everything needs to be working in sync to enjoy a good, clean, smooth motion in your shoulder. And the final group of structures are the other soft tissue structures like the tendons, the ligaments, the capsule, and of course the labrum, which confers stability to the joint. And so a lot of today's talk is going to be about the glenohumeral ligaments and the labrum. So why do we get shoulder instability? You all know the shoulder is like a ball and socket joint, and it's very much like a golf ball on a tee. You know, the surface area of the tee, which is akin to the glenoid, is only about 1/3 of the whole diameter of the ball. So what actually makes it a better socket to hold the ball in place would be the labrum and the capsule. If you were to get a dislocation or a tear to that labrum, every time that head were to push against the labrum, you are either at risk of a dislocation or you'd be having pain or some form of subtle subluxation or instability. So these tears in the front of the labrum or the anterior inferior portion of the labrum are called the Bankart tears. And these give rise to your anterior instability. They form about 3/4 of all labral tears that we see. The posterior labral tears form about 10%, and the slat tears form about 15%. Now, they can occur as discrete tears, or since it's a continuous structure anyway, the tear may just propagate from 90 degrees to 180 degrees to 270 degrees, or even a full 360 unstable tear. So the symptoms, what are the symptoms that a patient may present with? I mean, recurrent dislocations, obviously one, but without frank dislocations, the other thing they may complain of is this instability or this pain whenever they go into the ABER position, it's abduction, external rotation. And that's because at that point, the head is pushing against the anterior labral tear, okay? So the Bankart lesion or that anterior inferior labral tear is the cause for most of these problems, okay? But sometimes there are other associated injuries as well, okay? Another thing to note is that when you have a high recurrence rate that correlates with your age at your first dislocation. So let's say if you had a first dislocation in your 20s or your 30s, your chance of a recurrent dislocation is about 90%. However, as you get older, the chance of recurrence actually drops down because, as you know, as you get older, you tend to get stiffer as well. Okay, but other problems may then occur with dislocation. We'll go into that later. So yeah, so the other lesions I was talking about that you can also see in shoulder instability would be the Hill-Sachs lesion, which is this posterior indentation at the back of the humeral head. It occurs because, you know, each time the shoulder pops out to the front, you know, you get this glenoid jamming into the back of the head, and you get a defect that over time just gets bigger and bigger till you get this bone loss. Sometimes you just need one bad dislocation to crank itself there to get this defect. Okay, and generally when you have bone loss, you know, just treating the Bankart lesion alone is not going to be enough. Similarly, sometimes the patient may injure the glenoid side of the joint, and then you get a bony Bankart lesion. And again, that will require, if it's sizable enough, that will require more than just simply addressing the Bankart lesion. So generally, when you have a Hill-Sachs lesion or a bony Bankart lesion, these are not good signs. So how does the shoulder instability occur? Well, generally it's when you get an injury to the shoulder while in the able position. You know, it could be while you're going in for a throw or making a serve, or sometimes when you have an opponent or a player colliding into you and you're in this position or you're going to fall. So you can see what happens is the shoulder pops forward and you've got this telltale squaring of the shoulder. That's when the acromion is now denting that contour of the deltoid. You can see the squaring of the shoulder you see in all these patients. That's because the normal ball has popped out to the front and somewhere here in front of the patient. And so what's causing that indentation is now your acromion sticking out, as opposed to the normal contour of the deltoid that you have in an intact joint. Sometimes people get it from generalized loose ligaments, but that's another complex monster to discuss and manage, and we're not going to cover it in this talk. So in the history, I guess the questions you need to be asking the patient is...
Inside steps like this?
The first episode, how did it happen? Was there a trauma? What was the position of your arm? How did you put it back in? And in your subsequent episodes, you know, were they traumatic episodes that led to dislocations? Were they atraumatic? Were you just reaching? Were you sneezing? Were you driving? Was it a frank subluxation or a frank dislocation or a subtle subluxation? Each time, could you put it back in yourself? Did you have to go to the hospital to get it done? Could it be done under sedation? Or did you have to go under anesthesia? All this gives you a kind of a judge of how severe the patient's condition is. If they have bilateral apprehension, that's generally a sign that this could be a generalized ligamentous laxity problem. However, there are patients, you know, that do have traumatic injuries to both shoulders and tear the labrums on both sides, and that could be the cause for it. When a patient has mid-range abduction instability, meaning instability without even having to go to the full 90, that's generally a bad sign, as is instability that occurs during sleep as well. It's also important to know the patient's job, you know, whether they're the manual laborer, whether they work at height, whether they're a diver, what their dominant arm is and what sports are, because it helps you kind of decide whether this guy is going to need something done early, or can he afford to wait, or can he afford to have another dislocation, you know, if he would be working at height, or he was his job was a diver or a professional athlete, for example. So in the physical examination, I mean, you check the patient's range of movement and their strength and their overall neurovascular status, and all three of these will usually be intact. Okay, what I would then look for is the apprehension tests, because you know this is a labral tear; it's a continuous structure. So you do the anterior apprehension test maneuver like so, but I also check the posterior apprehension, which is when you just bring the arm across and push it backwards, as well as the O'Brien's test to look for the slap tear. But as we all know, you know, I find the posterior and anterior apprehension tests pretty sensitive. But as we all know, the O'Brien's test is not as sensitive. It's probably only about 30% sensitive and specific. Next, you know, you also want to take a history and check for generalized ligamentous laxity, that's your Baton scoring. And you want to check also for the Salter sign, or if the patient has multidirectional instability. Because if generalized laxity was an issue, a simple, arthroscopic Bankart repair may not be the solution for this patient. Generally, those patients require a lot of intensive rehab, possibly even a capsular application. And then I always check on their baseline external rotation compared to the other side, because generally with any of these procedures where you're doing an anterior stabilization, some people do end up losing the external rotation. So you need to have that baseline before you start off. And then next we move on to the radiographic evaluation. And so the first thing to do is your x-rays, your AP views and your axillary views. Now in the AP views, you check, is the joint back in position or not. Number two, you could see things like over here, oops. You can see he's got a bony Bankart defect here. And on this x-ray here, when the arm is slightly internally rotated, you can see a very huge Hill-Sachs lesion as well. Now the axillary view is the most reliable view to see whether the joint is actually end located or not. And on this axillary view, you can see it's quite flattened at the back, which is another form of Hill-Sachs lesion. And you can see this is the front because this is a coracoid process. So this patient also has got this Hill-Sachs lesion at the back. All right. Next, we do an MRI scan, and that will generally confirm your labral tear. It will show you the extent of the labral tear, whether it extends superiorly or posteriorly. And it can also show any other concomitant soft tissue pathologies. For example, in the second picture here, you can see a huge Hill-Sachs, but you also see a rotator cuff tear, which happens when your patients are slightly more elderly, like over 60, and when they sustain a dislocation. Sometimes on the MRI scans, you can also see bony Bankart lesions, you can see here. But generally, the best scan to show these bony lesions would be your CT scans. And if you're really concerned about the size of the Bankart lesion, bony Bankart or the Hill-Sachs lesion, we would always order a CT scan, because that would show the bone very clearly, as you can see. And here's a 3D recon helping you to visualize it much better. So the Bankart repair, Arthur Bankart described the Bankart lesion and the treatment back in 1923. That's 100 years or almost already. And it's been the go-to procedure for shoulder instability since. Nowadays, we're doing it all arthroscopically. But I will say that, the open Bankarts are still being done and practiced widely in places like UK, in Europe, and even the States. I myself have never seen an open Bankart repair done yet. It's been all arthroscopic ever since I was a little baby trainee. But so here are the benefits of an arthroscopic versus an open Bankart repair. You would have less surgical morbidity, shorter length of stay, less post-op pain. It's just 2 little keyhole scars you can see in the picture there. So less blood loss. It's a day surgery procedure, so the costs are less for the patient. Overall complication rates are less. Obviously, there's better cosmesis, and you'd have a faster post-op rehab and an easier rehab process as well. And generally post-op a better range of movement. Just quoting some evidence, this is a systematic review of 26 studies comparing all the aspects of the Bankart repair, and whether you tighten the rotator interval, whether you use 3 anchors or less or more, whether you use knotless or standard anchors, whether the material of the anchors matter. And as you can see, there was no statistical difference in the risk of recurrent dislocations with regard to all those different criteria. What actually affected the risk of recurrence post-Bankart repair were patient factors. So it's important to focus on these these risk factors when you select your patients. So what are these risk factors for recurrent instability even after a Bankart repair? Okay. Generally, the young punks, the males under 25, those that are subjected to recurrent trauma, the collision athletes, those with an increasing number of dislocations, those who have had prior procedures, stabilization procedures done, and those who have got Hill-Sachs lesions or bony Bankart lesions, and those who've got tears of their glenohumeral ligaments, or those with generalized capsular laxity. I'm not sure if you're aware, there's this ISIS score, not related to the terrorists, that was previously described, and it helps you kind of prognosticate based on the risk factors and the points you award, whether a simple Bankart surgery would suffice or whether a patient would need something more. So, I mean, just to share what we do in a Bankart is, in an arthroscopic Bankart, first you go in and do a diagnostic scope, you look at all the structures, you assess the Hill-Sachs lesion, if there is one, whether it engages with the glenoid. And then what we do is, then we need to liberate the Bankart lesion. So I'm just showing you these pictures. So this is the tear of the labrum. And first we liberate it, and then we need to prepare the glenoid rim to maybe roughen up both surfaces so that it can heal. Then we start stitching it, and then we drill it in and put it in with anchors. And so when you're done, you've got a nice big bumper again to hold that humeral head back in place. Okay? And we also routinely perform a capsular shift. So, at the lowest most anchor, the lowest most point, we grab the tissue from the capsule as well as the glenohumeral ligaments to tighten up the joint so that, the patient won't have that apprehension or the instability whenever they go back into these overhead positions. So this is a typical repair. I tend to favor this single working portal technique that was very popular back in the NUH. All of us are doing that. Just have one portal for the scope, one portal for stitching, and it's very easily done. Of course, there are other techniques that sometimes when I'm bored, I like to do. You can do these fancy mattress type techniques that give bigger bumpers, but generally, the outcomes are all very similar. Patients do very well if you choose your patient correctly. So the post-op protocol, I mean, this kind of varies. I see in overseas meetings, some people immobilize the patients very long. I generally give the sling for comfort only, and that's only for at most 2 weeks. Most of the patients usually wean off the sling by the 3rd or the 5th day, and possibly only wear the sling when they're commuting in public to avoid any collisions. The only restriction I would put initially is to limit the external rotation to about 30 degrees for the first 6 weeks, because you don't want to stress the anterior repair. But after 6 weeks, anything goes. And then general, the timeline is to achieve your full range of movement and strength by about 3 months, and to try and return to sports by about 3 to 6 months or so. Contact sports are a bit different. If you're doing a Bankart surgery and you're going for contact sports, usually we defer return to like rugby and judo and stuff for about a year. So what are the causes of failure when you do a Bankart surgery? One is doing it in the wrong patient with multidirectional instability. The other one is doing it in patients who have significant bone loss, because for these patients, there are a host of other procedures that probably should be done concurrently or instead. When you do a poor mobilization of the Bankart and the lesion in the labrum, you're not able to bring it back onto the glenoid face to hold the head properly. And sometimes, you don't put enough anchors, or your anchors aren't low enough, and that can be a cause for failure as well. So that's a surgical error as well. Now, next we come into the remplissage. Now, what is remplissage? Remplissage is French. It's a French term which means to fill in. So as you can see in the diagram here, that's the back of the humeral head where there's a defect. And what they do is they put in an anchor and they stitch in the infraspinatus tendon and the capsule to fill the defect. And what this does is, you previously had this intra-articular defect in the joint that you've now converted to an extra-articular defect. You've covered it up, and it also acts like a check rein. So it'll by tenodising it here, it'll stop your head from trying to pop out the front. Okay, this is what it looks like in the scope, where you put in the anchor and then you put in the sutures. It's all going out through the muscle, and once you tie it in and cinch it in, here it's very nice. It's as if the muscle just inserts straight onto the bone here like that. I'm not a big fan of the remplissage, and reason is because there is quite a lot of data to show that by stitching your external rotators and your capsule back into the head over there, you kind of limit your external rotation subsequently. So it actually then becomes a balance of the instability versus stiffness or loss of rotation. So you can see the evidence regarding remplissage. This is a biomechanical study that shows quite clearly, your internal and external rotation by the shoulder is significantly less in, this is an intact shoulder, the blue, a Bankart is a green, and the remplissage is the purple. So you can see that The remplissage has significantly less rotation with the arm by the side. Less rotation with the arm at 90 degrees abduction, but not as significant. Significantly less extension, and significantly more stiffness than an intact shoulder or a bang cut, a post bang cut shoulder. And there's been lots of evidence over the years that shows that you get this loss of rotation, external rotation, because of the tenodesis effect. And other studies show that yes, you have improved patient scores, you don't have recurrence, but maybe you only get about 80% of your rotation again. And another one summarizing that no matter what kind of remplissage technique you use, whether you put it in the middle of the valley or the edge or the opposite edge, all the techniques enhance the stability but cause stiffness. So I'm not a big fan of it, but there's definitely a role for it in my practice, and I'll just share a case here. These are the kind of cases where I always tend to do a remplissage. You can see this was a 60-year-old right-handed lady, and she had a fall and had a first dislocation at 60, and her shoulder was put back in. Now, in the first 3 days following her dislocation, the shoulder popped out 4 times. Each time it popped out, she went to an emergency department, and they just popped it back in and told her, look, your appointment with the doctors in 2 weeks' time, just stick to that. And that happened for 3 days in a row. Finally, on the 4th day, she decided this is not going to work, and she tried to see someone else, and then that's when she came to see me. Now, you can see on the x-ray that there's this huge Hill-Sachs lesion. Let me get back there. Huge Hill-Sachs lesion. And she was so unstable that even at rest, she was a bit chubby. So at rest, her arms would be about there, and they would still pop up. So when she got admitted, we got her scans done, and then you could see, in addition to the huge Hill-Sachs, she's got a rotator cuff tear, and that's that big Hill-Sachs defect at the back. So since I'm going to have to repair that rotator cuff back to the head anyway, this would be the kind of case that would work very well in remplissage. So for her, I just did a arthroscopic bang cut, did a remplissage, and this was her at 6 weeks. And that's pretty decent at 6 weeks. And you can see that the external rotation on the right and internal rotation is less than the opposite side. But for her, for her age group, for her demands, it was really good. And this is only 6 weeks. It did get better over the months that followed. So now we come to the last one, the ladder J. And this is everything in the kitchen sink almost. So that's Michel Ladder-J. He's also another French surgeon that described the procedure. And how it works is by a triple blocking effect. In a Ladder-J, what we do is we would cut the coracoid with the attached conjoined tendon, and we transfer it to the front of the glenoid rim. So, you've got a bony effect caused by the additional bone block there. You've got a sling effect caused by the conjoined tendon that will now act like a sling under the arm when you're in able position and causing support. And in the whole procedure, we're also tightening up the capsule and repairing the labral. So there's a triple effect to it. This procedure has also evolved over the years. We're doing it arthroscopically now during a variety of ways. Either we're using screws or even endo buttons. There's a lot of research going into it about whether we should be using additional washers and plates, whether we put the bone block on its side, on its back, or on its end. And so it's a very effective tool for people with severe instability. So the indications for the ladder J would be anterior shoulder instability, which cannot be successfully treated with a bang cut repair. And what I'm going to do is now go through a few case examples of the different kind of scenarios where it'd be helpful. Okay. So the first one is glenoid bone defects, obviously. This is a patient of mine. He was a 22-year-old male. This was only his 3rd episode in 6 years. It happened after a motorbike accident, but he felt that it was more painful than the others. And you can see on just the plain X-ray alone that he's got this big bony bang cut lesion there and a bit of flattening of the head there. So this is a CT scan. We did a ladder J procedure for him, and he was able to bounce back very quickly after that with no loss to his range of movement. One thing you can see on the X-rays, the Asian coracoids are much smaller than the Western population Caucasian coracoids. It's only an inch and sometimes smaller. So sometimes you can't fit the 2 screws. it can be a bit dicey in terms of rotational stability, but you do what you got to do. So far, if you get the positioning right, trajectory right, and compression right, they do very well as well. Here's a gentleman with a large Hill-Sachs lesion. He was a 40-year-old male. He's already got hypertension, cholesterol, sleep apnea. In his heyday, he was a judo player and he had a lot of dislocation in his youth, but he didn't treat it. And now he just got married and he got fat or even fatter. And he recently started having recurrent dislocations again after this long break. And the troubling thing is now, because of his sleep apnea and whatnot, each time he had a dislocation, he'd actually have to undergo anesthesia just to put it back in. And so he came to me for treatment. And this was the chap that had this huge Hill-Sachs lesion. So it was such a big lesion. You could consider remplissage, or you could do a ladder J. Here on this MRI scan, you can see the lesion and you can see the torn labrum over there. So he was a big guy. So his coracoid could take two screws and he bounced back very fast after. And he had very good range of movement. He's not an active guy, but he doesn't have his dislocations anymore. Another indication would be, even for a first-time dislocator, would be contact athletes. Here was a young guy in his 20s, so you can see there's already 2 risk factors according to the ICIS score. 3. Now, if you look at his sports, he does martial arts, he does rugby. He's had more than 10 episodes in 2 years. That's 4. So you can see all the risk factors piling up. And so you would think that bank cut would be a small operation, but with all these risk factors, you're probably destined to failure. So I did a ladder J for him. You can see his initial episode was traumatic, but subsequently all his episodes were atraumatic. And there you can just see a little soft tissue Bankart lesion, not much of a Hill-Sachs, no bony Bankart. So he had a ladder J and he was able to go back to the sport and faster than you'd be able to go back if you had just done a Bankart as well. And another clear indication for ladder J procedure is previous failed Bankart repairs or failed stabilizations. This gentleman was a 34-year-old male engineer whose work involved him climbing ladders daily and climbing at height. So it'd be really risky to have a dislocation while you're in the able position at height, right? He had 2 previous Bankart repairs done at 2 different institutions. One was 13 years ago and he had multiple recurrences after that, even on sleeping. After the second one, 10 years ago, there were no further dislocations, but he always had that pain on his able position. So, on his x-rays, you can see it's pretty flat. There's no bony Bankart lesion. His head looks pretty flat in the back. It's very shallow Hill-Sachs. You can see the trajectories from the previous anchors for his Bankart repair. Since he's at 2, I'm not going to do a third one. Einstein has said the definition of madness is doing the same thing again and again, expecting a different outcome. So he had a ladder J, and he did very well after that. No further recurrences. So for those of you who have never seen one or don't know what it's about, this is what we do in an open ladder J. Okay, so we do a small incision just over the coracoid. Okay, that's us coming in. And so this is the coracoid and the attached ligaments and the muscles. We'll have to detach the CA ligament, detach the pec minor muscle as well, and then we saw off the bone. Okay, and then with the little bone fragment, we drill through holes that put the screws through. Now, as you can see, this bony fragment is usually just about 1 inch or less. This space is about 1 centimeter. These holes are about 3 millimeters each. There's really not a lot of real estate. So there's a real risk of accidentally fracturing this and then having problems. So the next step then will be to split the subscap, find the anterior glenoid rim, and that's where you transfer this bony block after that. And then we tighten the capsule and repair the labrum on our way out again. So this is what the x-rays would look like. So what are the complications with a ladder J? Okay, number one, I guess specific to it would be all the coracoid graft complications. As mentioned, the risk of fracture is one. Another risk would be, over time, sometimes the bone resorbs and it kind of disappears. And this is a feature of the remodeling that occurs, and when it resorbs, sometimes you're just left with a screw prominent over there. So that may sometimes need to be removed arthroscopically. the positioning also is very critical. You position this block too lateral, you're at risk for arthritis. You position it too medial, and then it's not helping, not doing anything at all, you're still going to get recurrence. And we're talking about millimeters, just a millimeter off either direction, and then you probably have these complications. Okay, then the other risks such as malunion, non-union, the graft doesn't take, or you've put your trajectories wrong and it doesn't sit well. The other kind of surgical complications, kind of standard with any kind of surgery that you may perform, but it is true that in the latter J may have more complications than say an arthroscopic Bankart or an arthroscopic remplissage may have. It all boils down to, I guess, the surgeon's familiarity and the numbers they perform to keep the complication rate low. So the physio, post-op physio, post-lateral J is quite similar to a Bankart actually. For me, it's no different to my Bankart protocol, except initially a little bit of holding back on the extension as well in that first period. This might interest you guys. This is just out in Sports Health journal this year, and there was a study looking at about 31 different published rehab protocols in the States from various ACGME accredited institutions, comparing the Bankart and lateral J protocol. So the first row of numbers are the Bankart, the second row of the lateral J, and you can see the Bankarts, more of the Bankart protocols required immobilization compared to the lateral J, and there are longer average timelines for the Bankarts to reach their goals. For example, to get full passive forward flexion was like almost twice the time of the lateral J. To get full passive external rotation was about a third longer than the lateral J. Normal scapulothoracic movement was 14 weeks versus 9 weeks, and return to sport, you're looking at about 32 weeks versus just 20 weeks or less, and all those were significant. So what's the evidence regarding the lateral J? The lateral J has the lowest recurrence and dislocation rate, and it actually has a less loss of external rotation compared to a Bankart pen. So those are all good points. There is, however, a risk of development or progression of arthritis that can occur in the long term. So this, while in the short term, you're great, you've got no pain, great range of movement, no instability, in the long term, it can give rise to arthritis. Number two, and I always mention this to the patients, the coracoid process is like what we shoulder surgeons call the lighthouse of the shoulder. Whenever we do surgery, if you're lost, you don't know where you are, you just put your finger, feel the coracoid, and then you know where everything's at. But now once you've transferred it around and shifted the whole anatomy, you're kind of lost. So after you do a procedure like this, it would make subsequent shoulder surgeries or open shoulder surgeries challenging for the next guy. Hopefully it's not you. So what about arthroscopic lateral J? That it's quite in vogue nowadays. There's studies to show that you need to do about 30 to 50 arthroscopic lateral Js before you can even attain any kind of steady state competency and efficiency. And they suggest that actually only surgeons that expect to undertake such high volume should even begin to adopt this procedure. And there are other studies that show that both open and arthroscopic have excellent and comparable clinical outcomes, but the higher costs of arthroscopy, the steep learning curve and the higher complication rate do not appear to be justified by a benefit to the patients. There are certain centers, in Europe, in UK, US, where they do it in very high volume, and they could do it in half an hour or so. But not everywhere is at that level yet, and I would say including Singapore. Most shoulder surgeons still tend to adopt the open approach. So what is the evidence regarding Bankart versus the remplissage versus the lateral J? So in this study, it was a matched cohort study comparing Bankart and remplissage patients versus the open lateral J patients. There was a significant difference in terms of the loss of external rotation in the remplissage group. You can see 10 degrees versus 3 degrees with the arm by the side, and 13 degrees versus 0.3 degrees with the arm at 90. And there was also a significant difference in residual pain in the remplissage group, almost twice the number. There was, however, no significant difference in terms of the recurrence rates, and the outcome scores between these two groups. Okay, and then you go 1 year later. AJSM is actually the highest impact factor ranked orthopedic journal currently. And so this was a review looking at 56 studies, 4,300 patients, comparing Bankhart's open and arthroscopic with the Remplissage with open and arthroscopic lateral. And what you can see is that the highest recurrence rates belong to the arthroscopic Bankart, 16%. The lowest recurrence rate belong to the open lateral J, is only 5.7%. You look at complication rates, the highest complication rates go to the arthroscopic lateral J's, and that's probably because of the steep learning curve I mentioned before. Now, while the lowest complication is here under Bankart and Remplissage, you should note that the number of patients is only about 200. Very close by, just 1.6, and 2,006 patients was arthroscopic Bankart. So you can see the arthroscopic Bankart generally actually has very, very low complication rates as well. And this is my final article. It's just hot off the press, still in print, 2020 in the Journal of Shoulder and Elbow Surgery. This was a systemic review looking at 12 clinical trials comparing the Bankart Remplissage, and the open lateral J. And it concluded that there were significant differences in recurrence and revision rates between doing a Bankart and a Remplissage, almost 4 times higher for just a Bankart alone. But there were no significant differences in the recurrence and revision rates between the between the Remplissage and the lateral J. There was, however, a significant difference in the complication rates between the Remplissage and the lateral J, and this is kind of echoing what we saw in the previous study. So, you know, it's not really clear, you know, what should we do, because we know what gives us good outcomes, but, you know, there's also the loss of rotation, the loss of the stiffness on one hand to consider, with the complication rate on the other hand to consider. So in summary, recurrent shoulder instability in young contact athletes and patients with previously failed procedures, multiple procedures, and those with bone loss, either on unipolar, just either the ball or the socket, or bipolar on both sides, would be a very complex problem. And there are still no clear answers on the optimal management for them. And I think as you guys are the treating caregivers and we the surgeons as well, you got to know your risk factors for recurrence instability, even without treatment or even with treatment like a Bankart, and also be aware of which are the indications for where patients need something more than just a Bankart or Remplissage. And these are generally those with the bony defects on the glenoid, the large bony heel sacs lesion, those who are contact athletes, those who are subjected to recurrent trauma, those with any of the failed procedures, previous stabilization procedures, and any other patient that is deemed to be at high risk of failure with a soft tissue repair. And going by the previous literature, these tend to be those young males with an increasing number of dislocations over a long period of time, those with lesions or tears of the glenohumeral ligaments and capsular laxity as well. Okay, so with that, I thank you very much for your time. I hope you enjoyed the talk. Thanks a lot, guys.
Thank you.
Bye-bye.